Hello and welcome. Today we're going to tackle a topic that pretty much every medical student and junior doctor comes across: neonatal jaundice. It's one of the most common things you'll see on the newborn ward. And let me tell you, getting the diagnosis right is absolutely crucial. So, let's just jump right into a typical scenario. Imagine you're on your pediatric rotation. You walk into the nursery and you see a newborn with that classic yellowish tint to their skin and eyes. So what's the very first question that should pop into your head?
Exactly, that's the big one. Is this just a harmless, temporary phase that a lot of babies go through, or is it a major red flag for something more serious going on? Being able to tell the difference, that's the core skill we're going to break down today.
Okay, so to really answer that normal versus dangerous question, we've got to start with the basics and define what we're actually looking at. For your exams, the definition is pretty straightforward. Jaundice, or its medical term, hyperbilirubinemia, isn't a disease in itself. It's a sign. It's that yellow color you see in the skin and in the whites of the eyes, and it's caused by high levels of a substance called bilirubin floating around in the blood.
And this is incredibly common. We're talking about nearly 60% of full-term babies and up to 80% of premature babies developing some jaundice in their first week. So because you're going to see it so often, you really need to be confident in how you approach it.
So why does this happen so often? And more importantly, how do we know when to worry? Well, to figure that out, we need to take a quick look at how a newborn's body handles bilirubin. Let's trace the pathway.
Think of it like a simple supply and demand issue. First, newborns just naturally break down their red blood cells way faster than adults do. This creates a huge supply of bilirubin. Second, the baby's liver, which is like the processing plant, is still pretty new to the job and can't process or conjugate all of this bilirubin efficiently. So what happens? You get a temporary buildup of this unconjugated bilirubin in the blood, and that's what makes the baby look yellow.
Okay, so now that we get the normal pathway, let's get to the really important part. What happens when things go wrong? This is where your clinical skills really come into play.
When you see a jaundiced baby, this is your number one job. You have to figure out which of two buckets it falls into. Is this physiological jaundice, that normal temporary process we just talked about, or is it pathological jaundice, which means there's an underlying disease that needs urgent investigation?
Now this slide is your clinical cheat sheet, really. It lays out the key differences perfectly. Pay super close attention to the onset time. Here's a rule to live by. Jaundice that shows up in the first 24 hours of life is always pathological until you prove it's not. Also, just look at the baby. A healthy, active baby who's feeding well, that points toward physiological. But a sleepy, lethargic baby who isn't interested in feeding, that's a massive red flag. And this slide right here is why we care so much. It's specifically the unconjugated bilirubin, the kind the liver hasn't processed yet, that can be toxic to the brain. If those levels get way too high, it can cross into the brain and cause permanent neurological damage.
Okay, so for your exams, and of course for safe practice, you absolutely have to have the red flags for pathological jaundice memorized. These are the things that tell you, stop, I need to investigate this now.
These are the red flags you just have to know. Jaundice in the first 24 hours? Investigate. The bilirubin is rising super fast, more than 5 milligrams per deciliter per day. That suggests something like hemolysis is going on. Red blood cells are breaking down too quickly. And definitely pay attention to the diapers. Pale or clay-colored stools and dark urine are big clues for cholestasis, which is a problem with bilirubin excretion.
Let's also clear up a really common point of confusion that loves to show up on exams: the difference between breastfeeding jaundice and breast milk jaundice. Breastfeeding jaundice happens early, in the first week. It's basically due to the baby not getting enough milk. The fix? Improve the breastfeeding. Breast milk jaundice happens later, and it's caused by something in the mother's milk itself. The key here is you do not stop breastfeeding. It almost always resolves on its own.
All right, that was a lot. Let's do a super quick recap of the most important things to take away.
So remember these core ideas. Jaundice is super common. Your job is to spot the dangerous kind. Physiological is normal, shows up after day 1, and the baby is doing great. Pathological is a warning sign. It's there in the first 24 hours, the levels are too high or rising too fast, and you have to act on it to protect the baby's brain. And that really is the crucial point, isn't it? By spotting pathological jaundice early and acting on those red flags, you're not just treating a number on a lab report. You are actively preventing a devastating and totally irreversible complication called kernicterus, which is just another name for bilirubin-induced brain damage. And that, right there, makes all the difference.